I'll go back to Farshid. So sadly, we can see that's not a good story. And if anything, it really makes us wonder if things could have happened relatively earlier, where rather than pushing for one intervention after the other while watching the liver functionality worsening, what would have been your ideal with this situation in regard to systemic therapy intervention? Where would you have done it?
So really, in the spirit of multidisciplinary clinic, if that patient had presented to our institution today, we would have tried to harness the benefits of all liver-directed therapy, systemic therapy, put him in on the trial where we do local regional treatment and combine it with deepening response by giving an anti-VEGF agent and maybe make it durable by giving a checkpoint inhibitor. So I think that this would have been my ideal for this patient before the patient progressed to that stage. But the other avenue that's opening up now with more effective treatment, systemic treatment that actually give us a response is now whether something like lenvatinib that gives us 40% modified RECIST, and if you look actually at a waterfall plot, many more patients will have a tumor shrinkage than it's reflected in the RECIST criteria as an adjunct or as a systemic treatment to try to reduce this patient, downstage this patient, to see whether this patient might become actually a transplant candidate, for example. Now, the data are not here. We need to generate the data. We have to see whether it will hold up to what we know with local regional treatment and downstaging and going to transplant. But certainly now we have the tools to start asking those questions and try to more aggressively manage these patients.
So what we heard so far is that sadly this patient that Riyad has presented came with rather relatively advanced cirrhotic component, and if anything was treated with embolization on more than one occasion, while sadly the liver functionality continued to worsen. We're not necessarily saying, but this could have happened naturally. This is really what occurred at the end of the day. But already, as you can see on the table, there are other options that could have been there, including what Riyad mentioned, got to radioembolization that probably could have controlled disease in a more expensive way rather than the localized chemoembolization. Number two, we heard about the potential for a certain further intervention with now that the responses are available to start with lenvatinib, also the checkpoint inhibitors, as we mentioned, Pembro and Nivo. In addition to that, we have data that at least we know or suggested to us that could also bring in a great response, among which, as we all have seen, there was a press release. We don't know the data yet of the combination of atezolizumab plus bevacizumab. We have also the data that was reported, at least in the phase 1 component of lenvatinib plus pembrolizumab. And also we have the durvalumab plus tremelimumab, the anti-CTLA4 plus anti-PD-L1. So there's quite a bit going on, as already Farshid mentioned. But one thing that all three of my colleagues already have brought up, and I have to admit that I don't have a full understanding of, and I'm going to go back to Riyad on this, downstaging. What's that?
So in general, downstaging is a term that's used in the transplant context, which is, while we know that patients that present within Milan criteria have a certain 5-year survival, is it possible that if you take somebody outside those criteria and shrink them and make them within those criteria, and then demonstrate sort of that the biology is there to support that, can you impart the same type of benefit? More recently, that concept's now been expanded to the surgical side now in cirrhotics. And so can I downstage somebody that's initially inoperable for whatever reason, size, for example, location of tumor, into somebody that's more operable? So the idea here is that you take a patient that's otherwise not transplantable, not resectable, you downstage them, and that's the term, and then you potentially make them transplantable or resectable to a possible cure by using a local regional therapy. And again, that's what we have traditionally enjoyed in interventional radiologies with the local regional therapies where you have this. But again, with the advent of some of these therapies like lenvatinib with 40.9% response rate or so by mRECIST, now that that narrative is there in level 1 evidence, can we use mRECIST criteria to support that? And again, I think that that narrative is now being expanded.
I can see you're ready to kind of give your view. And you know what? I'm really very eager. I was going to ask you because I'm not sure I buy this.
Oh, no, so there's actually, I completely agree with Riyad, actually, but there's data that show that if you actually get downstaged, you have equivalent survival than as those who start with the Milan criteria. So this is actually started from the UCSF group. There was actually data from Texas and Oklahoma as well, and now this is national policy.
Amazing.
So I think this really is important for everyone who treats HCC to know, because you started by describing the Milan criteria, which is the traditional criteria that was described by Mazzaferro and has been the lay of the land for years. But downstaging now means that anyone who actually has local regional disease, you have to consider, can I downstage this patient and make them a transplant candidate? And this is an important concept because those patients then have 5-year survival that exceeds 60%. So this is a cure for their liver disease, this is a cure for their HCC. And so, Farshid, you mentioned, for example, when we think about systemic therapy options, we can use the TKIs and we can use, immunotherapy. But I think it's important that these patients are discussed in a multidisciplinary fashion, because if you treat that patient with local regional disease with immunotherapy, at least at this time, we currently don't know if that affects post-transplant outcomes, and if so, how it impacts post-transplant outcomes. And so thereby, if you treat a patient like this who has liver dysfunction, local regional disease, with one of the checkpoint inhibitors, you may be impacting their chance of getting a transplant and their post-transplant outcomes if they get it. So I think that's where early referral, discussion in a transplant setting, multidisciplinary setting is critical for these patients.
Well, again, if anything, I give a lot of credit for Riyadh to bring this rather challenging case and share it with us, because if anything, we learned that multidisciplinary approach is critical. Number two, in early diagnosis and early intervention will be key. A close monitoring of the liver functionality, and we learned quite a bit from Amit about how to make sure that liver function is preserved as best possible. As we can see from all the ideas that were brought up on the table, including the multiple choices of local therapy, including radioembolization as well, in regard to systemic therapy with all the choices that we brought up in regard to lenvatinib, sorafenib, and then Rigo, cabozantinib, ramucirumab, nivolumab, pembrolizumab, and now the advent of the data in regard to the atezo plus bevacizumab, in regard to lenvatinib plus pembrolizumab, and durvalumab plus tremelimumab. We have a lot that could be going on in regard to that disease. But more importantly, and this is an important learning point, is we go back to what Amit just brought up. The data from the UCSF and many other as well have shown that downstaging is not necessarily a pure component of biology-related idea that is really false, but rather is true, i.e. control of disease, bringing down, is actually can be contributing based on that data to improved outcome, i.e. you are curbing down a certain biology evolution of the disease per se. So by all means, again, maybe where we started, multidisciplinary team, same like we're sitting on that table, will be very critical for our patients.